So let's go ahead and take a look at the lower part of the respiratory system, looking first at the bronchial tracts and bronchial divisions. What we need to remember is that each of the bronchial divisions will head into a specific lobe of the lung, where we're going to have two primary bronchial pathways on the left side and three primary bronchi on the right side. The branching number 4s is an indication of the number of lobes that we have. The difference in the number of lobes is based off of the anatomical of the heart within the mediastinum that takes up the area where one of the lobes of the lungs might be. Where we go from the trachea, number 1, to the right and left bronchial branches, 2 and 3, to the primary bronchial branches from those, number 4, where we have the upper, middle, and lower branches on the right, and simply upper and lower on the left. From there we have secondary branches, number 5. The secondary bronchial branches will head to the distinct areas of the lobes of the lungs. And then from there we're going to go to number 6, which are the tertiary branches. These tertiary branches will then head to the alveolar ducts, where we're going to end up having air exchange at the lungs. So let's take a look at how these bronchial branches overlay within the anatomy of the lungs. We end up having two superior lobes, a right superior lobe and a left superior lobe, which is going to come away from that upper branching. In the left superior lobe, we have an area known as the lingula. The lingula overlies the heart and is one of the anatomical structures that will minimize the amount of stroke volume that the heart can have during inhalation and exhalation. Because we do not have the heart to worry about on the right side, we end up having a division within the lobes where we end up having a middle lobe on the right side that is not seen on the left. Then we have the inferior lobes. The lobes are divided based off of fissures, where we have a horizontal fissure between the right middle and right superior, and then an oblique fissure between the middle and inferior lobes on the right side, and in between the lingula and superior lobe with the inferior lobe on the left side. The lungs themselves are held in place in an inflated state due to an adherent factor that happens post-birth. There is a chemical known as surfactant that is secreted. This surfactant acts as a glue adhesive that adheres the pleura between the lungs, the viscera, and the pleura of the thoracic cavity, the inferior or deep area of the thoracic cage. Because of the adherence between these two pleural layers, the lungs will remain at an inflated state at all times. This inflated state is referred to as residual volume. When the pleura is disrupted, we can have a pneumothorax, sometimes referred to as a tension pneumothorax, that will lead to collapsion of the lungs. The surfactant is released the surfactant and the inhalation of the lungs and the remaining of the inflation of the lungs occurs when the mucus plugs are removed from the infant post-birth. As we work our way into the alveoli are open, sacked, single cell layered or simple squammal epithelial cells. There is no connective tissue support to the alveoli. The alveoli themselves are held in place due to passive air pressure from the residual volume that remains within the lungs at all times. What we have to remember is that the alveoli and the alveolar sacs themselves are highly vascularized, and we have a single cell layer thick tissue. The single cell layer thick tissue allows for maximal rate of diffusion, and maximal volume of diffusion will occur as we have increased amounts of total surface area, which we'll get to at Fick's law as it relates to diffusion of air at the alveoli. The high vascularization allows for maximal rate of and maximal amount of gas exchange in between the pulmonary capillaries and the alveoli themselves. In the alveoli, we have three distinct types of cells. We have the type 1 cells. The type 1 cells are the typical simple squammal epithelial cells that will make up the bulk of the alveoli and ensure that we have continuous gas exchange. Then we have the type 2 cells. The type 2 cells are responsible for production of the alveolar surfactant, which keeps the alveolus as a sphere. In the next slide, we're going to take a look at what the shape actually looks like and how that shape ensures that we have a maximal amount of gas exchange. The last are the embedded macrophages. The embedded macrophages are there to ensure that any pathogenic material that enters into the alveolus is taken care of in terms of an immune response. So if we look at the alveolus, we have a cluster of spheres. These clusters of spheres ensures that we maximize the total surface area of interaction. If we were to have one single sphere, we would only have one sphere of surface area for interaction to occur at. However, as we have multiple spheres, we now have multiple spheres of surface area to have interaction with. People who have COPD, emphysema, or lower respiratory damage, where the alveoli pop, end up losing this multiple spherical structure. When they lose this multiple spherical structure, instead of having two spheres for exchange to occur on, they now have one sphere. Or instead of having 5 spheres on which exchange can occur on, they now only have 2 spheres. Embedded around the alveolus and around each of the alveolar balls or alveolar spheres is a network of capillaries, the alveolar or pulmonary capillaries. The alveolar pulmonary capillaries is going to be the area of gas exchange between the alveolus and the cardiovascular system. The airflow that enters the alveolus is going to enter the alveolus through the alveolar pore. The alveolar pore is going to be at the apex of the sphere. Surrounding the sphere will be the respiratory membrane and the simple squammal epithelial cells. Embedded around that will be the capillaries. Now, if we notice here, we have multiple spheres interacting with multiple capillaries at the same time. This allows for maximal rate of gas exchange to occur in the minimal amount of time. We also have the surfactant secreting type 2 alveolar cells to ensure that we have the multiple spheres so that we have maximal amounts of gas exchange occurring. And we have those embedded macrophages to ensure that any type of pathogenic material that gets into the alveolus will be taken care of in terms of an immune response. What to remember is that the direction of gas exchange that will occur is based off of the partial pressures of the individual gases within the alveolus versus the capillaries, where we're going to move based off of diffusion of the individual gas within the bulk flow of the atmospheric medium or atmospheric solution. So if we have high oxygen in the capillaries and low oxygen in the alveolus, we're going to move from the capillaries to the alveolus. If we have high oxygen in the alveolus and low in the capillaries, we're going to move from the alveolus to the capillaries. So it doesn't matter what we're looking at in terms of the gas. What we have to do is we have to look at what is the partial pressure of that gas and how does that partial pressure going to influence the direction of motion.